Welcome back everyone to part 2 of this topic. And in this part we're going to talk about ARDS, which is acute respiratory distress syndrome, pneumonia and tuberculosis. Now before we start on ARDS, I just want to do a little overview of restrictive disease. Remember, with restrictive disease, we're talking about decreased compliance, which is another word for a decreased ability of the lungs to stretch. The alveoli need to be able to expand on inspiration, but also need to be able to recoil on expiration. However, when there's decreased compliance, the volume difference between inspiration and expiration is reduced. There's a decrease in all lung volumes and therefore a decreased forced vital capacity and forced expiratory volume in 1 second, or FEV1. As a result of this, the ratio of FEV1 to FVC is normal, so it can look like 80% or higher. And this is because all lung volumes are decreased. Remember, with the obstructive, FEV1 to FVC is usually less than 80%, and that's because there's an obstruction in the airways. Here, it can look normal, and it can actually even be higher. As a result of that, there's compensation and there's increased work of accessory muscles, but overall there's inadequate ventilation, decreased oxygenation, and leading to hypoxemia. Now, I've just put some examples of restrictive diseases up there in blue. Pneumoconiosis, due to the inhalation of asbestos dust, and that causes asbestosis, so inflammation in response to the asbestos dust. And then, eventually in genetically predisposed people, that can develop into a cancer called mesothelioma. We also have silicosis. Again, that's an inflammatory response to silicon dust. And then we also have pulmonary fibrosis. So if you can imagine, inflammation happening on an ongoing basis, and that in response to that, scar tissue forming. And scar tissue is not as stretchy as normal tissue, and that's where the restriction comes into it here. And the one that we're going to talk about is acute respiratory distress syndrome, or ARDS. And we're going to be talking about its pathophysiology and then how it's treated with medication. Now, ARDS itself comes on quickly, so it has an acute presentation. It's very sort of dramatic in its presentation, and it is life-threatening. It is sort of related to older age, and it often accompanies sort of multiple organ failure when somebody is in end of sort of life phase, but can also come on by itself. And there are many different causes for it. The most common, I guess, is sepsis. And it can also be caused by a trauma to the lungs, and it can also be caused by, aspiration of gastric contents into the respiratory system. And lots of different drugs and drug overdoses can also cause acute respiratory distress syndrome. So if we look at the pathophysiology behind it, whatever the cause is going to cause some sort of a clinical lung injury. That's then going to stimulate massive pulmonary inflammation and severe pulmonary edema and hypoxemia. The injury to the pulmonary capillary endothelium is going to exacerbate this pulmonary edema and hypoxemia and trigger or stimulate platelet aggregation and thrombus formation. Now, what I want you to think about now are the cells in the respiratory membrane, so those epithelial cells, and we have type 1 pneumocytes and type 2 pneumocytes. These type 1 pneumocytes are the ones that are involved in gas exchange, and so these are about 90% of the alveolar epithelial cells, and they're very fragile. Remember, they're very, very thin. So they're going to be damaged very easily, by all of this inflammation, and they fill up with fluid, and that will then thicken the respiratory membrane. So you're going to get reduced carbon dioxide clearance, reduced blood oxygenation, and overall, reduced gas exchange. Now, the second type of epithelial cells are these type 2 pneumocytes, and these are those cuboidal shaped ones. There's far less of them compared to these type 1 pneumocytes, and they are a bit more robust than these really fragile ones. Remember, these are the ones that produce surfactant, and surfactant is that detergent-like substance that lines the alveoli, and it reduces the surface tension so that the alveoli don't collapse then on expiration. However, with all of this inflammation going on, they also get damaged, and the surfactant tends to get washed out, and there's less of it being produced, and therefore this leads to alveolar collapse and to the sort of stiffness in the lungs, right? And that's what's causing the restriction here, which is this stiffness. Now, ARDS does develop acutely, so usually within 24 hours of the initial lung injury, whatever it was that caused that lung injury to begin with. Can result in death due to respiratory acidosis. So here we're talking about all of that fluid accumulating, decreasing gas exchange, therefore carbon dioxide being retained and accumulating and decreasing body fluid pH to cause respiratory acidosis. And there can also be reduced cardiac output due to hypotension, and that's got to do with the inflammatory response. In terms of treatment, supportive, so things like anti-inflammatories would be given. If the causative agent is a bacteria, then IV antibiotics will be given. But, it's mainly those sort of things, and then supportive to maintain tissue oxygenation and minimize lung injury, and people with ARDS will often require mechanical ventilation. Now, I've just popped this here again. We've been through it a couple of times now, and we're looking at the FEV1 in relation to restrictive lung disease. Here we have our normal breathing pattern with that forced vital capacity there of 4 liters. And because here it is a restrictive disease, the forced vital capacity is going to be lower than the normal one, but also we have over here the FEV1 is also going to be lower than the FEV1 for the normal breathing pattern. So as a result of that, the FEV1 to FVC often looks normal, but when you go and you look at the actual volumes, you can see that they're both reduced, and this is indicative of a restrictive lung disease. Okay, so now we're going to look at pneumonia. Again, a little bit about its pathophysiology, and then a little bit about how it's treated. So what is pneumonia? It's inflammation of the alveoli and the bronchioles due to an infection of the lower respiratory tract caused by bacteria. So pneumococcus or Haemophilus can also be caused by viruses such as influenza, can also be fungal, caused by protozoans or parasites. Now, while everybody can get, pneumonia, there are particular sort of risk factors associated with it. Advanced age is one you'd be very familiar with. Being immunocompromised, having an underlying lung disease kind of, make you more susceptible to pneumonia, alcoholism, smoking, and immobilization. So if you're stuck in bed for a long period of time and fluid can build up on the lungs, then that can promote an environment which is really, susceptible for infection, right? Or really promotes infection. Now, remember everybody, for a pathogen to get down into the lower respiratory tract, it needs to be able to overcome the mucociliary elevator and also the cough reflex. Now, if it can do that and it gets down into the lower parts, it's going to stimulate inflammation. And that inflammation then is going to cause alveolar damage and also capillary damage too. And so you're going to have this mismatch between, ventilation and perfusion, and that's going to lead to, hypoxemia or low oxygen levels in the blood. In terms, though, of the consequences of it, this is kind of dependent on the causative microorganism, which influences the clinical presentation. For example, if it's bacterial, right? Some bacteria produce toxins, and those toxins can cause further tissue damage. And that's why bacterial pneumonia is often more serious than viral pneumonia. And so it will also depend on how the pneumonia should be treated. So, for example, bacterial pneumonia being treated with antibiotics, they're no good. For viral pneumonia, although there are some antivirals, on the shelves now, or via prescription, such as Tamiflu. So, with the onset of pneumonia, there is this initial infection, immune activation and inflammation, damage to alveoli and the terminal bronchioles. They causes them to fill up with all fluid and infectious debris and a serous exudate. That will lead to the sort of sign of infection in the lungs, which is that productive cough. But remember, there's also going to be signs of systemic inflammation as well. So fever and chills, and that general feeling of really not feeling well at all, so that malaise. In terms of diagnosis, this is done via a physical exam, so listening to chest sounds by auscultating the chest with a stethoscope, white blood cell counts done for infection, chest x-ray, respiratory secretion, and of course blood culture. So respiratory secretions being those sputum samples and blood cultures. And then the pathogen is identified by blood or sputum characteristics in culture. So obviously, if it grows on a agar plate, it's going to be some sort of bacteria or fungus. Now, in terms of treatment then, viral pneumonia, mostly, there are some antivirals, as I mentioned, but mostly supportive therapy in terms of, fluid intake and also analgesics. With bacterial, antibiotics, of course. And then there's also, involvement here for chest physio, good hydration, good chest hygiene, practicing sort of that deep breathing and coughing. And as I mentioned, a big role for the physiotherapist in this.